How many of you are on a low carb or keto diet? Raise your hand, please. And how many of you have been on it? Keep your hands up. How many of you have been on it more than 6 months? Keep your hands up. How many have been on it more than a year? Keep your hands up. 2 years, 5 years, 10 years. I know you might have to do some calculations here. 15 years. I see two hands. How long have you been doing a low carb diet?
Probably
22 years. And 20 years. So I think we're all in the same both area. How about a round of applause for these folks? Now, people say it's not sustainable. What do you say to them? It is. So someone says it's not sustainable. Think of it and say, no, it is. And they'll go, oh okay. Because actually there's no evidence that it's not sustainable. So actually, and Mitzi, thank you for that talk. It's as if that was what I grew up with, the evidence-based medicine. And a little bit about me. Is there anyone here who's a plant by the plant-based group? Oh, Chris, thank you. I always thought Keto Chow was a plant-based thing. It is, but anyway. Okay, and anyone kind of flirting, brought by their spouse or friend here, they really wanted to just go out on the deck? Yeah, okay. So, Chris, can you remove him, please? And that's only because I met Trevor already on the cruise, okay? For those of you who think, what an offensive guy. So, reflections on 20 years of low-carb research and clinical practice and personal use. I started out at Stanford University. I was a history major, but I was pre-med all the way. Went back to the University of Wisconsin where I grew up, Madison, Wisconsin. Any Midwesterners, I guess I should say any Californians first, but so I had a very good clinical medical school grounding, and there were a few things that just didn't ring true. I learned in medical school that the liver will make more cholesterol if you lower it in the diet. So on the one hand, we were taught to do low cholesterol diets, low fat diets and all that, but your liver will make more cholesterol if you eat less of it. How does that jibe? Because you need cholesterol, right? I mean, this is in medical school as I was going through, and the other kind of smelling or suspecting we weren't taught everything. When we use fat, we store fat as energy on our bodies. In fact, we store saturated fat on our bodies as energy. How can saturated fat be bad for you? We store it in our bodies and use it over and over. It's like, so I left medical school as sort of I really didn't know much about nutrition. Went to the University of Kentucky in Lexington. The only training I got in nutrition in internal medicine training, which is we're known as the thinkers in medicine, right? We're the ones we're the detectives, figure out the tough cases, and that was me. I love Sherlock Holmes, and wanted to be a detective, and the only nutrition I got was in what was called total parenteral nutrition, or TPN. So someone enters the hospital, they can't eat. Well, if you could put a tube in, you would give them tube feeds. But so basically I learned that through the vein, you put in protein, amino acids, and you put in fat. There was no bread. There was no fruit. Well, what will you do if you can't eat fruit, right? You don't put fruit in the vein, doctor. So how do I put all this together, right? so I end up being sort of kicked out of internal medicine there because I was a chief resident, which means you're the resident who, the chief who kind of corrals the other residents and keeps them out of the attending's hair, the teachers, right? And they finally said, you ought to go get more training in that lecture you just heard, evidence-based medicine, so why don't you go down the street to Duke? And so I've been at Duke since 1990. And general internal medicine, and I'm giving this information for those of you in the medical field, is known as the teachers, the evidence-based medicine. The Siskel and Ebert of the research world is general internal medicine. I was at McMaster University in 1990 studying evidence-based medicine before it was called evidence-based medicine. And I realized that's being called a hipster of evidence-based medicine because you were into it before. I don't know, okay. So I'm a clinical epidemiologist, which means basically what you see in front of you is valid, like you just heard. If you hear 1,000 anecdotes about something, doctors will brush it off, that's anecdotal. In fact, in Kentucky they said antidotal. And I'm like, oh, I'm sorry, they also, they don't get the, anyway, forget it. I couldn't totally learn the dialect there, but I ended up in North Carolina. And so now I'm an author on 120 research papers, so going through that process, but that's what I was trained to do, wrote my own grants, and now you need an army of people to write grants. That's entirely changed. I was asked to be an author on the new Atkins for a New You because Dr. Atkins had died. And actually I went around, this was so controversial, although I didn't know how controversial it was, I decided if I'm going to study something, and there were two patients of mine at the VA who lost over 50 pounds. One of them came in and said, I asked, what did you do? This is something I don't see very frequently. And he said, all I did is eat steak and eggs. And now you don't think that's controversial because you've heard Dr. Berry speak. But in 1998, that was a shock value statement on purpose. All I did is eat steak and eggs. I see it didn't shock you. Dang. Well,
it's a daily meal.
It's a daily meal. Well, I was shocked. And most people, I think, back then was shocked. So these two people lost weight, and one of them came back, and I said, well, I did a little research, and I think your cholesterol is going to go up. So I don't want you to do this diet. Remember, for me, this is 24 years ago. And he looked at me and said, doctor, why don't you check my cholesterol if you're worried about it? I said, okay. Sent him down to the lab. His cholesterol was better. How many of you have seen doctors and they won't even check your cholesterol because they know it's going to be worse? Right. At least one of you? Two? Several. Okay. Maybe it's a general truism. But so I was shocked to see cholesterol actually getting better. And people telling you to do diets that didn't make sense physiologically in my training. So I visit Dr. Atkins, Dr. Eads, Dr. Bernstein, Dr. Rosedale. These are all doctors of that era. And I asked Dr. Atkins, what do you do? I want to study it. And so I borrowed his list of foods that he had created for 30 years in a clinical practice with Jackie Eberstein. And a shout out for Jackie Eberstein, the nurse that worked with Dr. Atkins. Any of you know her? Yeah, she's been a mentor of mine. Jackie, thank you, Jackie. Turns out you go to the clinic and it worked. Of course, I went back to Duke, finally saying, I'm studying this. And one of my superiors said, well, you went to the clinic, huh? New York City? Huh. They probably hired Broadway performers to come in to be patients. No lie. The disconnect. And yet today I offer people to come to my office to shadow me. And one of the reasons I set up a clinic was to keep that as a teaching opportunity, because so many different reasons, it can't work, can't be true, can't be, until you see it in action. For a doctor, you can just assume it's not going to work, it'll be bad, it's not sustainable, but you know all of those things. So I got roped into several books, Keto Clarity, Cholesterol Clarity, just signed one today. Your story is fantastic, and thank you for your stories. I love hearing that. And then the latest latest book, End Your Carb Confusion, and a companion cookbook just this last year. But looking back, reflecting, getting the communication, the information that I know now, so we started doing research, and then other people started doing research. There are now so many randomized controlled trials that there are at least 4 meta-analyses of randomized controlled trials, not meta-analyses of observational studies. That was the dig that Mitzi gave. So meta-analysis doesn't necessarily mean it's a meta-analysis of randomized trials. It was a meta-analysis of observational studies that Mitzi talked about. If you didn't get that nuance, okay, don't worry about it. So now there's enough research that if there was a drug approval process for diets, like a diet approval process at the FDA, it would be FDA approved. There's so many studies, but there's no process for FDA approval for a diet. Anybody can just write a diet book. Who is that Westman guy and End Your Carb Confusion? I want to make sure that whoever you're learning from has some credibility, some research, I gravitated toward Dr. Atkins because in 1998, he was the only one who still had a clinic that I could visit. Everyone else had either retired or closed their practice. And just to say, Dr. Eads and Mike and Mary Dan retired by 1998. I just saw them at the Metabolic Health Summit in Santa Barbara, and they're flourishing in retirement. So it's not like they have stopped doing things. And if you don't know Mike and Mary Dan, they're fantastic. But along the way, so any of you still kind of skeptical about this? Be honest. We won't throw you out. Well, I was, and if there's a pivotal book that was influential for me to read, it was Gary Taubes' book called Good Calories, Bad Calories. So if there's you're just here starting from scratch, skeptical like we all were, or many of us were, you got to read Gary Taubes' book. And now if it's too harsh, too dry, too scientific, fortunately another investigative journalist named Nina Teicholz wrote a book called The Big Fat Surprise, and it's much more readable. It reads more like a detective or whodunit sort of thing. Gary's is just it's scientific, but more references than needed, but he had to do that, and it was pivotal for me because I got into a research area where it went against everything we've been taught. Everything. You're not supposed to eat fat. You're not supposed to have salt. Cut out that red meat. No eggs. Well, I'm not an early adopter. So you got my bio, my background, kind of middle, not the best schools, not the worst schools, but what drove me and kept me was data. So I kind of blindly did a study with 50 people over 6 months, published it in the American Journal of Medicine. And so I'll say, if you say, well, what about the proper human diet? And I'll say, well, give me a paper, 50 people over 6 months, published in a peer-reviewed journal, and then I'll comment on it. How harsh is that? That's the evidence I require in evidence-based medicine in Duke University. So I can't publicly say, even though this is quite public, can't publicly say that you should do a carnivore diet until there are some studies out there. Now, fortunately, I'm at that level of academia where I can ask people to do papers, and I found some places to help get them published. And Amber O'Hearn did a great paper on, can a carnivore diet be totally nutritionally adequate? And it was a pretty good piece, a pretty good manuscript that said, yeah, it's probably everything you need. And this doesn't rely on the hunter-gatherer, primal, paleo, ancestral. That to me is supportive, but it's not true science by today's standards. So I'm not trying to tell you don't do it. I'm just trying to tell you why I'm at that point where I can't say that, and don't say to my patients, just go ahead and don't eat any vegetable matter. But what I teach is pretty close to a carnivore diet. So on my program, if you came to me, I'd say, eat as much as you want of meat, poultry, fish and shellfish and eggs. These are the proteins. You need protein. Protein comes first, even on a keto diet. Okay, protein comes first. And you can have a limited amount of cheese, creams, and oil, and mayonnaise. You can have 2 cups of leafy greens, and you can estimate a cupful by your fist. Go home, compare your fist to a measuring cup. Half a fist is half a cup. 1 knuckle is a quarter cup, the volume. It's a great way to estimate. 2 cups of leafy greens, 1 cup of a non-starchy vegetable, the ABCs, asparagus, broccoli, cauliflower, you know the non-starchy veggies. And that's it. And I teach people to do this, and people, hunger goes away after 1 to 2 days. Has anyone experienced your hunger going away with whatever you're doing? Yeah. And then you eat less automatically, and it's generally 1 to 2 pounds per week in a clinical population like mine of weight loss. And so, if you're wondering if you're losing fast enough or slow enough, if it's been 1 to 2 pounds per week, that's about what I see in my clinic. So just to give you a context for that. So I'm presenting the research at an obesity meeting, and the obesity meetings now for the research is pretty much all drugs and surgeries. But we presented our first diet data at the Obesity Society, it's called, and I am a fellow of the Obesity Society. But I gave the talk, and then I'm walking out, and out of the dark came this person, Dr. Westman, I need to talk to you. I'm like, okay. It was Steve Phinney. Now, does anyone know Steve Phinney's name? Well, he's really the godfather. That's why I was, Dr. Westman. No, he didn't talk like that. But Steve is one of my mentors who took me aside and was explaining why what we were taught wasn't right, and all of the going way back about membranes and omega-3, omega-6. And he was doing his biker study in the 1980s, long before the studies we were doing, right around the year 2000. But so I've learned so much from Steve Phinney and Jeff Volek. Jeff Volek is not an MD, but he's a double PhD in exercise physiology and nutrition. And so Jeff Volek, V-O-L-E-K, leads one of the premier low-carb research centers at Ohio State. So if you're in the Columbus area, you want to get involved in research on this, look up Dr. Volek, still doing the research there. And so our clinical trials were very pragmatic. In fact, that was one of the limitations. One of our second, third, fourth randomized trial was diabetes, and we compared a low glycemic, meaning lower sugars, versus low carb, and low carb beat out low glycemic, even just with 50 people over 6 months. But people came back to me and said, well, we can't do research on that. You're doing too many things. I said, well, what do you mean? Well, the hunger's going away, they're losing weight, and their blood sugars are getting better. That you're not doing just studying one thing. So the diet does too much. For research, you want to focus on just one thing. And then what I learned some years later is that in the charter of the National Institutes of Health, our governmental research organization, is to find the mechanism of disease. You would think the goal is to improve human health. So no, that's not what the wording is. So I'm learning this, talking about it in my own local area. The fatty liver expert, who's still there today at Duke, 15 years ago, I presented this data. Look, we fixed fatty liver. We did a study with liver biopsies, and the fatty liver is gone. And yet doctors today will say, oh, you have fatty liver, you better cut the fat out of your diet. No, don't do that. No, it's the carbs that go to the fat in the liver. Cutting the carbs out fixes the fatty liver. That's true. So I go to the researcher, and she goes, well, that's great. So even 15 years later, they're not using the low-carb diet in the fatty liver clinic at Duke, because they're enrolling people in clinical trials of drugs to treat the fatty liver. So I learned at one of these fairs, there are 4 people with a very rare disease called McArdle syndrome. It's a glycogen storage disease where people run out of sugar or run out of energy in their muscle, and they get exhausted after just walking 10 or 20 yards. And 4 people get up and say, we're climbing mountains on a keto diet, and we don't know why. So I got interested in this glycogen storage disease, kind of learned in the big picture view, your muscle can run on sugar or fat. It's what's available. And if you have a problem of you can't store sugar in the muscle, but the paradigm of these doctors is, oh, we have to give them sugar all day long. They wake up kids with McArdle disease that can't store sugar in the muscle. They wake them up at night and give them sugar. They feed them resistant starches, which is this, the oatmeal and stuff like that you're probably not eating. Remember those things? Resistant starches get absorbed all day long to make sure there's sugar so that the muscle can have sugar and have energy. But the people feel terrible until they stopped sugar in the food. Guess what happened in the muscle? It started running on ketones and fatty acids, mostly. But so the keto diet really is a fat-burning diet. So it allows the muscles and the heart to run on fatty acids better. And in these people with a disease that over the last 50 years, modern medicine could not give them a fix, could not cure them, they fixed themselves. So there's a Facebook group, and the person who started the clinical series, which is the group of people we published on, now is influencing the world's researchers on this orphan disease to start studying low-carb diets. So I get home after a trip to London, England, where I sat down and briefed these researchers on, yes, you can feed people fat. It's okay. Because that was oh, well, these people are better by eating what? Eating fat? Oh my goodness, they're going to get heart disease. And so I had to go in and say, no, it's going to be fine. And after all, if you just study them for 6 months, especially, don't worry about it. So that research is percolating. I go back to my Duke genetic experts. We have a clinic on McArdle disease. I look it up. It really wasn't on my radar. Glycogen storage. I go in, doctor, we have a little meeting. I can help fix your patients. Look, these people are fixing them and we need to do research on it. I never heard back. You know why? Well, all of the patients are not on a drug trial. They're on a genetic reprogramming study where you feed people or give them a virus that goes in and changes the gene so that they don't have this problem regardless of what they're eating. But in the short run, what are they helping? So the medical world today, and the academic world in particular, is interested in learning new knowledge about mechanisms so that they can use drugs. I hate to have to say this. And it's been about 20 years for me to, again, reflecting after 20 years, medical care today is medication care. Yes. And so many of us get the lab values to look at here and, the cholesterol levels and all that. We use lifestyle to treat all of these metabolic problems, not drugs. It's okay to not be on a drug. And in their defense, this is all they know. We teach young doctors to give more drugs. I know it's sad. Well, one of the reasons I've helped to start a new organization after being president of the Obesity Medicine Association is to start an organization that doesn't even want drugs. Because now in the obesity medicine world, all these new Mounjaro, Wegovy, every doctor has become a weight loss doctor. Well, it doesn't mean it's healthy, and there are other ways to do it. Remember, like keeping the carbs super low. Just this year, 20-some years after my first patient seeing me, I woke up thinking, okay, I've watched a few episodes of Naked and Afraid. Has anyone watched that show? Yeah. Oh, come on, it's not so, you don't have to be guilty about it. Oh, no, they're not naked, sorry. They blur out the, and then there's Alone, which apparently they don't even have a film crew with them, which goes to the extra level. So these people, without eating pretty much anything at all, what are they burning for energy in their body? Fats. So we store fat as energy. So I woke up thinking, oh my God, everyone becomes a fat burner if you don't eat for 2 days. Everybody in this room if you don't eat for 2 days, you'll become a fat burner. How can this be bad? And then my phone went up and said, low energy. Do you want to go in safe mode? What happens to the human body when you stop eating? You go into safe mode. So I've gone from, oh my God, eating fat's going to kill you 20 years ago, to now considering the possibility that being in nutritional ketosis, or just not eating all that garbage, is actually better. Now, what we know scientifically is this thing called fasting, which means not eating, or not eating carbs. I want to make that connection for you, that you get the benefit of fasting, which is really fat burning, when you're eating protein and fat without the carbs. So fasting really just means fat burning. And you'll see studies of fasting and autophagy, fasting and longer life. And I think, metabolically, it's the insulin level that's down super low. But we're talking now about the same thing with different language. And that's something that I've found that I've often interpreted for not only professional to non-professional audiences, but even within cardiology versus endocrinology. So obesity medicine, my field, is actually kind of an orphan area in medicine. There are only about 5,000 of us around the country, but we know treating obesity will fix the high blood pressure and get you off all those medicines. It will fix the diabetes and pre-diabetes, get you off all those medicines. It'll fix the arthritis, or at least arthritis pain, get you off. It fix the fatty liver, the PCOS, anything that's related to insulin resistance will be improved or reversed by treating the underlying obesity. Really by whatever means, but why not just change the food like we teach? And I think it's advantageous in many different ways. There was something that Gary Taubes wrote in his book that, again, Good Calories, Bad Calories is a must-read if you're in the field of science, and you're going to have to understand and articulate to other people why we got it wrong, or at least didn't know everything. That's the diplomatic way of saying it, that we've learned things. And in there, he brings up the true is with most research, the more you study it, the more you learn, the better it should look when you go in a certain direction. And that never happened with the low-fat diet. The more the low-fat diet was studied, it never really worked until they finally teed up a study with 28,000 women, the Women's Health Initiative, a low-fat diet over 8 years, and it didn't work. And nobody talks about the $500 million that was put in the wrong basket to study, the wrong diet to study. What they, at the NIH level, that what they say is, see, lifestyle doesn't work. We'll just find the mechanism and use more drugs. So I'm not optimistic there will be another lifestyle trial, because you're fighting with people who want the mechanism and the drugs. And the pharma industry, of course, loves other people studying mechanism that they can then use that information for drugs. Of course, I'm not against drugs. I think for acute illnesses, you want drugs can be your friend, but for long-term chronic disease management, medication's really not any advantage over just changing your lifestyle, in what I see. So there's nothing wrong or nothing wrong or unsafe about being a fat burner. Everyone does it. If you don't eat for 2 days, you'll be a fat burner. If you eat just steak and eggs, you're a fat burner. I think even there are going to be efficiencies that we learn about. And this is now the new research about ketones that's very exciting. If you have ketones around, they're anti-inflammatory, in addition to the fact that you're not eating pro-inflammatory foods, right? So the new research on ketones and ketosis and the brain and neurodegenerative diseases is fascinating. It's not ready to sign off like here, it's going to work like a prescription drug yet, but that research is ongoing now. And the more ketones and ketosis is being studied, the better it looks, even in just the 10 years that it's been studied now. And so the way this world is working is, this last fall, I presented 2 cases of reversal of heart failure in my clinic patients. One woman, she's a pediatric ICU nurse. She lost 140 pounds, and her ejection fraction, or her squeezing of her heart, went from 20 to 50%, which is almost normal. And the naysayers will say, well, it was the weight loss. And of course, yeah, it was the weight loss. But so you show me something you can do. So anyway, we do too much. But I want the credit, I want the benefits of all those different things. So I'm presenting these case studies, and Steve Finney, remember Dr. Westman and I need to talk to you, years ago, he's become a friend, although we haven't really ever worked together. Well, there was one study we did up in Vancouver, outside Vancouver. It led to the documentary, the Canadian Broadcast Company documentary called My Big Fat Diet. And on the cover of the movie, there's this big guy with a salmon. I mean, big salmon. And so we helped a group up there, the First Nations group. Here we call folks Native American. They're called First Nations because we were here first. It's very good. So I did collaborate with Steve and Jay Wortman on a study. He was a Canadian doctor, and that led to a documentary, helped a town go keto. We called it low carb then. And what we learned later is that there was a dietitian there who left town when we were there and complained to their supervisors over in Ottawa and actually tried to sabotage. So we would go in here, do this. She'd come in, don't do that. Active sabotage on the study, because back then, eating fat was going to kill you. But the diet, so Dr. Wortman came to me and said, Dr. Westman, you studied the Atkins diet, yeah. I think that what you're studying is very similar to what the people here in the Northwest used to eat. It was fish, maybe some sea animals, seals. So basically it was the modern day version of an Atkins diet. And yet the dietitians trained in the American version, which the Canadian version picks up on American food pyramid and all that, got upset. And Jay got to put on a conference in Ottawa with the experts in Canada who are studying diabetes. And of course, the big diabetes study that was going on was studying drugs for diabetes, and it really wasn't very interested in studying a diet. And the world expert national expert for nutrition in Canada got up and said, there's not much vitamin C in an Inuit diet, but they never had scurvy, which is vitamin C deficiency. And so there's probably enough vitamin C in the meat. And then she said, but I still want you to eat 7 to 11 servings of fruits and vegetables and breads, like the Canadian pyramid tells you, in a research meeting. I mean, it's almost like, how do you know someone went to Duke? Just talk with them for a minute. Talk with them for a minute, they'll tell you, right? So they can't not tell you about the food pyramid, But anyway, so I learned pretty quickly that there's a lot of stuff in here that's not science. That it's a belief system, it's the theme that you hear today, and a paradigm view. And then it takes a long time to change that paradigm. So while I knew that this could work, 2 of my patients at the VA, I didn't know if it was safe, right? So you can read a book, you can do anything, and then there'll be the, what did Dean Ornish say at the Great Nutrition Debate? We're up in the USDA auditorium in Washington, D.C. Dr. Atkins is up there, and Dr. Ornish gets up there and says, you can lose weight with chemotherapy. Doesn't mean it's healthy. And that Atkins diet is like chemotherapy, was the implication, right? I have to credit Dr. Ornish publicly for putting lifestyle on the radar of something that's therapeutic, but I have to discredit and criticize that he said there was only one way to do it, and it was his way. So be careful of people who are mini scientists and then promoters, rather than scientists who, think of it, if you were selling cars and you sold Chevys, you wouldn't say, those Volvos, they don't work and they're unsafe. Well, I think they're actually safer aren't they? But you would say mine's cheaper, or So in the research, dietetic, and then diet promotion world, there's no need to ever, there's no accountability for what people say. So I hope if you've watched, my company is called Adapt Your Life, outside of Duke. And I have a YouTube channel that has hundreds of videos. You can go to Adapt Your Life YouTube channel and search constipation. And I have a video on constipation. Squatty potty, you don't have to poop every day. Anyway, all the details, more than you want maybe. But I'm teaching a lot of people online, and I came to that very, how should I say, slowly. I watched the diabetes group in the UK for 10 years treat people online for diabetes. And I would go to Arjun and Charlotte and say, have you had any side effects? Have you had any bad results? I'm worried about it. Well, the version of keto, low carb they do, 50 to 100 grams, is not going to give the same reduction of blood sugar and worry about medications. So how you do this matters, and how low you go on the carbs matter. But if you don't have any medical issue, you're not on any medications, every human becomes a fat burner if you don't eat carbs for 2 days. So protein comes first. You can run your body on carbs or fat. It's your choice, really. So if you're not eating carbs and you're alive, you're here, you're getting protein, and your body's running on fat. And I'm not saying ketones on purpose, because ketones still is kind of a minor player. You're a fat burner. Oh, right, 20 years ago I would say, you're a fat burner. It was like a stutter, because you can't tell people to eat no. You can eat fat. I did it without a stutter. So, I have to think that the feeling is as if, I know this is not science, is it? You're on a cruise to learn about medical things. Weird. There's a doctor talking about food. I practiced the best internal medicine of my life talking about food, not drugs. I know, it's strange. It's to the point where, I'm a big Indiana Jones fan, You ever watch, so the one time they meet the soldier, or the guy at the end who has the Holy Grail and the cup, and the bad guy comes in and goes, one of these is the cup of Jesus. It must be this beautiful one that's all shiny. And he drinks from it and he dies. He chose poorly. And so Indy goes up and goes, oh, which one is it? Because he knows now if he drinks it, he's dead, And he goes, he was a carpenter. It's going to be this simple cup. He drinks. He chose wisely. So, I'm a lapsed Lutheran, I have to say. And the feeling that doctors have when you start talking about your LDL is high, it's kind of like it's going against what they were taught, like a religion. And so if you're a scientist going into the church of LDL, you're not welcome, because it really has become the inertia that's almost like a religion. Now, I'm sorry, I can't tell what it says 18.
18:28.
Okay, so that means I have 18 more minutes?
Yeah.
Oh, fantastic.
It keeps crashing, but I keep fixing it, don't worry.
I thought maybe you're adding time. So what I've learned, here's some practical stuff, okay? So I learned, remember, just repeating, I asked Dr. Atkins what he did in the clinic. It's a sheet of paper, all on one sheet of paper. And I started learning about companies and, and how do you teach people and all that. If you can't fit it on one side of an 8.5 and 11 sheet of paper, it's too much information, right? Have you ever heard that? You got to keep it simple, and the whole KISS thing, keep it simple, stupid. So Dr. Atkins and Jackie Eberstein in that practice had worked out a protocol on one sheet of paper. So I said, I want to study it. went up with a research team. We sat in the office, and the hired Broadway performers convinced us, that one I just can't forget. And that fellow who said it just retired as the chief of the VA in Durham. So that I have to come back and remind. He forgot about it. Well, but then my friends back home, after all the studies are positive, go, oh, well, you were like shooting fish in a bucket. You know, it's not a hard thing to shoot fish in a bucket. You went and you cheated. You saw other people. Well, yeah, I asked Dr. Atkins, who did it for 30 years, what he did. Maybe he learned something. So I pitched the 50 people over 6 months. He pulls the check out of his blue blazer, writes out the $50,000 check. I'm going back to Duke and doing this study. So that was published in 2002. And the method I use is so simple, it can fit on an 8.5, 11 sheet of paper. And what happened over time, I'm using this, start a clinic, and treat people with all sorts of diseases. I mean, and it's the average, people come to me on 5 to 10 medicines if they're in Durham, North Carolina, and they're in the medical system. It's called polypharmacy, really. The people started coming in, well, you know, keto's so hard. At first, like, keto? What's that? You know, and I'm paying attention a little bit, but then there's like, well, you know, I only have 5 keto chows a day. Oh, well, you know, we didn't study Keto Chow or any products. Any of these we didn't study ketone drinks, ketone pills, soon there'll probably be ketone enemas. We didn't, and then this guy comes in and says, of course I'm having bulletproof coffee. I'm like, what the heck is bulletproof coffee? Dr. Atkins never talked about bulletproof. So what happened is the internet, the new keto word got out there, and all of these other things blossomed that had never gone through the vetting of the clinical research or clinical trials. And so I've developed a company, the Adapt Your Life Academy. Many of you here have gone through the class, thank you. Where basically we go back to the old Atkins method. In fact, if you could find and dust off your old Atkins book, I just teach people Atkins induction. But I can't call it that because everyone knows Atkins is bad. Mediterranean is good. So tell your doctors you're doing the Mediterranean diet. It's going to be smooth. It's like, oh, you're doing the Mediterranean. Don't tell them you're doing the optimal. I'm sorry, I don't remember Ken's program on purpose. The proper human diet. Don't tell them that. Just tell them you're doing the Mediterranean diet. Really, it will smooth that whole process. But the program I learned and studied, and then various versions of it, not all were as strict as what we teach, not all the other clinical trials. We focus on protein first, not fat. I hope if you're coming in with internet keto in your brain and you're having unlimited cheese, because there are no carbs in cheese, you're having unlimited butter, because there's no carbs in butter, you're going to get the inappropriate teaching that calories don't matter. So if you're stuck, you want to lose fat off your body, you don't want to be adding fats and oils in the food you drink. So the old way is focus on proteins to come first. Don't check a macro. Don't use an app. People have started coming into me saying, well, my app told me, what? My app told me I needed, what did your body tell you? I don't listen to my body. Okay, well, let's start working. So there's a whole process of unlearning this stuff. But I have to say, the amount of teaching I do in my clinic is, you know, assessing the barriers, trying to get someone to start it. Often I'll negotiate for just a day. You know, can you do it for a day? And I don't assess motivation. I don't really do much in terms of all these other kind of flowery things. Once you cut the carbs out, it's automatic for most people. And I think we get a lot of the talks here, and if it's your first time at a meeting like this, a lot of people do have trouble and need assistance. But I've learned that if you don't have any medical issues, you can do this on your own. It's okay. And being in ketosis is the default, like, safe mode. You can actually have economies, and if you have redundant path, your screen might be a little lower in intensity, but actually that lower metabolic rates are associated with longer lives. Do you know that one of the animals that lives the longest is the tortoise? Tortoise. Have you ever heard a turtle joke? Oh, that's even too fast. But so actually, the metabolic rate is inversely associated with length of life. So you want to have a slow metabolism, actually. And then people come to me wanting drugs now. I mean, that's one way to do it, but why not just use the food? Ketone monitoring is a mixed blessing. I don't ask people to monitor their ketones. In fact, the owner of Keto Mojo gives me a hard time every time we're together because, Eric, you never promote Keto Mojo. It's okay. My brand is Keto Made Simple. No measuring needed. Okay, I know, he says. But they're great people, as well as the bears with Keto Chow, one of the few companies that have kind of gotten in to help and actually give back to the field, which is fantastic. Thank you. But no monitoring. There are some people who never go into ketosis. So you're losing 1 to 2 pounds per week. Someone comes back to me, I'm frustrated. Why? You're losing 1 to 2 pounds per week pretty effortlessly. You're having steak and eggs and things you like. But I'm not in ketosis. Like, what? When did that become the goal? Oh, right, keto, diet. So then, back in the day, Dr. Atkins had measuring urine ketones in one of his first books. The best I can tell, they dropped it in the second book because it just caused too many questions and confusion. So if you keep the carbs under 20 to 30 total per day, not per meal. Sarah Hallberg came through my clinic, did the study at Purdue with Verta Health, wonderful person, wonderful doctor. And it's 20 grams. Somehow Sarah went through the clinic and started 30 grams total per day. So their study is 30 grams. But somewhere in there, Dr. Atkins even taught that you can find your ketone threshold. And you want to be at that place where you're in and out of ketosis. But even then, that became too problematic for people to try to figure that out. How many of you measured ketones? Just wondering. Yeah, so maybe a third. And urine, blood, breath, it's a different molecule. In fact, the kinetics of ketosis is not fully worked out. But so don't freak out if you're having success and you're not in ketosis, okay? The goal is success, not a certain keto level. And what a ketone level doesn't tell you is that you're using ketones and you're just not accumulating them in the blood. So it's still working. You don't have to have a certain ketone level. So I finally realized that how you learn the program makes all the difference in the sustainability. If you learn a complicated system, life gets busy, you're not going to be able to keep up the complicated system. If you learn a simple system, you get it grooved in, you're more likely to stay on track even when things get busy. And this I've learned from, I have to food prep. No, you don't. So I started using my own, I never cook, I'll tell people. Well, you don't cook? You don't? No, I have other people cook for me. Either restaurants or I might go by the gas station and get the little prosciutto mozzarella roll-ups. In a gas station, you can't get bad gas at the gas station. I tried to get junk gas. I couldn't. But I went inside and I could get a lot of junk for people, for humans, a lot of human junk food. But actually most gas stations, even in our area, have protein and fat. You don't have to choose the sugary things. But that's shock value for people. I always like to say something that is a little bit different than most doctors say. And I've said I probably don't unload all of this on people. I'll try to find, the major barrier that someone might have. But you want to learn a simple system. In fact, I think the carnivorous kind of thing, really steak and eggs, that's all you eat?
No.
Oh, no?
We sometimes have pork chops.
Okay. Steak and eggs, is that all you eat? No, sometimes pork chops. Okay? And in retrospect, if you were my patient, in 1998, I should have said, good for you. But I was the doctor. First time, oh no, can't be good. And my second fallback position was, we got to measure your cholesterol. Well, it was better. And then now clinical trials have been done all over. Your experience matters, right? And so now I go to the next level, which is if a doctor is worried about your vascular system, they want to put you on a drug for your cholesterol. They're really worried about your vascular system, that atherosclerosis thing, And so you want to measure your vascular system. You can do that now. Now, your doctor might not do it for you. You might have to go get a test on your own. In our area, there's a company called Lifeline Screening. They'll come around in dark of night in fellowship halls, in synagogue, fellowship room, and they put up their ultrasound machines and they give you a report. And if you don't have atherosclerosis by report, and you go in and your doctor says, I need to prevent your atherosclerosis that you don't have, let them explain that. It would be almost like, I think you have cancer, so I'm going to give you chemotherapy. Well, no, we don't do that. We make sure there's a biopsy of cancer before we treat it. How can we use a surrogate marker, meaning intermediate marker, a blood correlative thing that really doesn't correlate well as a treatment tool? It's because there have been studies of people with that cholesterol level. You put them on, you follow them, and if you've had heart attack or stroke, you have fairly good benefit if you're a carb eater in those studies. If it's primary prevention, meaning you haven't had a heart attack, you haven't had a stroke yet, using a drug treatment for the cholesterol is not very powerful. And it's almost insignificant, in my opinion. So you can go to the Mayo Clinic. Have you heard of the Mayo Clinic?
Oh, yeah.
That's the Duke of the Midwest. Mayo Clinic Statin Decision Aid. And if you ask me, I'll tell you again. So Mayo Clinic Statin Decision Aid, and it's a website. You put in your numbers, and it will give you a prediction, and then show you what treatment with a statin would achieve for you. It's pretty underwhelming to me to see my risk go from 2 in 100 to 1 in 100, which means 98% of the time I'm fine. If I take a drug, it means 99% of the time I'm fine. Now for you, that might be something I don't want to take that extra risk. So it's an individual, that's called personalized medicine or individualized medicine. So wrapping up. I have to say I'm grateful, proud, how should I say, I've mentored a lot of people in the research world, in the influencer world. A lot of that actually has been doing things that doctors don't normally do, which is coming on cruises and meeting people online. And I know that's weird. And well, no, it's just not the way we used to do it. I'm getting a little tired, and I'm usually just a few years after Ken Berry, so I can't, use the same language as Ken can. But I'm, getting kind of fed up with my colleagues thinking they can fix everything with drugs, and they don't even mention food.
Right. Yeah.
They don't even ask.
Right.
Or they might even give the plant-based biased thing, and that's frustrating. Although I'm not surprised. So I'm disappointed but not surprised. Someone said, tell them your feelings. So, okay. But medical care has really become medication care. And that I have not wanted to say that for a long time, but I've really fallen out of that system. So what can you do? Well, inform yourself, monitor yourself, get the vascular system measured if you're worried about that. You don't have to teach your doctors about this, but I mean, you can. That statin decision aid is great to, well, doctor, you have the internet, can you pull this? Yeah, have them do it right in front of you. Well, it'd be nice to know, your result before you do it to be sure it didn't say you're going to need a drug. But if your HDL is super high, it's probably not going to happen. But I'm afraid. So in the clinic, I can do a lot. I can help a lot of people. I can reverse medical problems. The need is so much greater. And there's a metaphor in public health and in just health in general that we're working hard saving lives in the clinic, but there's so many more people that need the help. If we could only go upstream, so we're pulling people from the stream, we're saving lives, we go home, we're sweating, at the end of the day we feel good, we saved a life, but we got to go upstream and stop people from jumping in the river of carbs. And as you see, that's not easy. It's full of addiction and all that, but how can we still have commercials on TV for sugary cereals for children? That would be like having, I grew up with candy cigarettes. Remember those? I wanted to be like mom and dad, and sugar in the, oh boy. But so the people who I see, and I learned a lot from Dr. Atkins, although he died right before we published the second study, so I wasn't able to learn from him. But I learned some things, like you don't be a doctor and then go up and be in front of the Congress. You want other people to do that. You want people to be trained in that. So I'm staying in my lane in a clinic on purpose. And so what we have is Rob Lustig, who's a professor at the University of California, San Francisco. He went out and got trained in public health, and he's trying to rustle up some activity in a book called Hooked. Michael Moss, who wrote Sugar, Salt, Fat, Finding the Bliss Point, kind of a whistleblower. The industry makes food so you can't stop eating it. His latest book, Hooked, tells the story of trying to get the legal action against companies. And it's not easy, but I think there's going to have to be action like there was against tobacco, big tobacco, to get a societal change. For policy, if you want to get involved, you can. The Nutrition Coalition was started by Nina Teicholz, the investigative journalist who wrote The Big Fat Surprise. Nina is devoted, and I asked her at one of the last meetings, so there's a Society for Metabolic Health meeting on the West Coast, that's San Diego, and then on the East Coast, that's Boca Raton. I asked Nina, why as an investigative journalist, you wrote this book years ago, why are you still doing this? And she said, it's a matter of social justice. It's a matter of doing the right thing. And I was just like, oh gosh, But so the Nutrition Coalition is trying to do the fight up at the congressional level, but the companies lobby the government. The food pyramid never had any data behind it. It was all lobbying of the government. Fortunately, now it's uninterpretable. It's is it the rainbow or is it the my plate? Is it, when someone comes in and says, yeah, there's this government thing. I'll say, what was that shape? And they, good. We don't even want the P word to be out there, right? It's the pyramid. No, it was wrong. It was basically marketing food America makes through a governmental guideline, which was not based on health. If you need more information, right now I'm in that mode of helping in the academic world of reviewing papers and grants, trying to keep people from getting outrageously, unscientific reviews that happen still today. You might have a great study, but if it says keto is good, it gets rejected. It's a discrimination thing. But I'm still in the academic world for that. I'm in my clinic at Duke 4 days a week, consulting 1 day, but you can see me in Durham. There might be a little wait. Sorry about that. But you can access all of these different things at ericwestmanmd.com. So that's my website. The free information from my company, Adapt Your Life, is at Adapt Your Life YouTube channel. And then we've taught many of you through the Adapt Your Life Academy, where we have classes, and everyone gets slammed into a Facebook group for 3 weeks to help you get started, to get over that hurdle. If you need that advanced level of teaching, we have that too. So really there's you can get page 4, if that's all you need. That's just the list of foods. You can get a book, End Your Carb Confusion, and a great cookbook by a master chef. Scott Parker did the End Your Carb Confusion cookbook. I love it. But I'm trying to get information out in ways that is accessible and affordable, and really, in the words of one of my nieces who came to town, she shadowed me in the clinic, and she said, "God, Uncle Eric, all you do is tell people to not eat carbs, and you get paid for it." It's a pretty good gig. But if you have medical problems, I'm helpful there. I do more than just that. But although this last summer, one of my patients took herself off 600 units of insulin over 8 weeks, just with the caution that you always have to check your blood sugar before taking your insulin, like you were taught originally, remember? And then if the blood sugar is ever under 100 or 6 millimole, don't take insulin, for heaven's sake, at that time. You'll be surprised at how many people don't know that. And some people don't even know what insulin does. It's just another pill, another kind of shot to do. So I hope I can relieve some anxiety or fear, or maybe get you to stimulate you to keep on the path, reboot, restart, or just continue with measuring everything we normally would with health. And thank you so much.